عليكم السلام بنتي.
اليوم أستاذ إن شاء الله المحاضرة أنا ودكتورة رؤى راح نقدمها، فجزء علي وجزء علي. أنا راح أقدم كدبر أناتومي، هي راح تقدم إن شاء الله راديولوجيكال أناتومي.
كل زين، تفضل.
إن شاء الله. بسم الله. Anatomy and radiology of the female genital tract. The female genital tract consists of internal genitalia and external genitalia. Regarding internal genitalia include vagina, uterus, fallopian tubes, and ovaries. The uterus is extraperitoneal pear-shaped muscular organ lying between the bladder and rectum. It measures about 7.5 by 5 cm and has fundus, body, and cervix. The fundus of uterus is the part above the level of the uterine tube, while the body is the part of uterus from the level of the uterine tubes to the level of the isthmus, which is the narrow part just above the cervical canal. The cervix is the part of uterus below the level of the isthmus of the uterus. Relation of the uterus, anterior relation. Anterior relation to the body of uterus is vesico-uterine pouch and superior surface of the bladder, while supravaginal part of cervix is posterior surface of the bladder, and vaginal part of cervix is anterior fornix of vagina. Posterior relation, the body and supravaginal part of cervix, recto-uterine pouch and coils of ileum and sigmoid colon, while the vaginal portion of cervix, posterior fornix of vagina. Lateral relation include on each side, body and supravaginal part of cervix, broad ligaments and uterine vessels, while the vaginal portion on each side, lateral fornix of vagina. The cervix. It is typically about 2.5 cm long. The upper end communicates with the uterine body via the internal os, and the lower end open at the vagina at the external os. In children, the cervix is twice the size of the uterus, and the uterus grows disproportionately until they are of equal size at puberty. In adulthood, the uterus is twice the size of cervix. Pelvic peritoneum in female. There is a pelvic peritoneal reflection in the female, which include recto-uterine Douglas pouch or cul-de-sac, which is the reflection of peritoneum from rectum to the upper part of posterior surface of vagina, while the vesico-uterine pouch, reflection of peritoneum from uterus to upper surface of urinary bladder. Regarding the ligament of pelvic peritoneum in female, one of them is a broad ligament, which is double layer of peritoneum that includes the fallopian tubes in its upper part and extend from sides of the uterus to the pelvic side wall and floor, and it consists of 3 parts. Mesometrium, which is that part supports the uterus, and mesosalpinx is that part surrounds the uterine tubes, and lastly mesovarium is that part contains ovarian branch of uterine artery. Ligamental support of the uterus include a pubocervical ligament, which run anteriorly from the cervix around the base of the bladder to the pubic bone, and the transverse cervical ligament, which is the cardinal ligament, which run laterally from the cervix and lateral aspect of vaginal fornix to pelvic side wall, while the uterosacral ligament, this is the uterosacral ligament, which run posterior superiorly to the mid-sacrum on the upper surface of the levator any muscle. The round ligament is a fibromuscular band that pass the upper lateral part of the uterus to the inguinal canal, ending in the labium major. Sorry. Regarding the muscular support of the uterus, it consists of levator any muscle, which has three muscles, puborectalis muscles and iliococcygeus muscles, and iliococcygeus muscle and pubococcygeus muscle together act as active support to the uterus. While the visceral support, the bladder supports the uterus on its upper surface in the normal anatomical arrangement, which will provide a passive support. Now we'll talk about normal position and axis of uterus. We have two terms, anteversion and anteflexion. Anteversion mean angulation between the long axis of the cervix, which represent this red line, and the long axis of the vagina. It's about 9 degrees. This angle represents about 90 degrees. And anteflexion, which represent the angulation between the long axis of the cervix and the body of the uterus, which represent this angle. It's about 120 to 170. The normal position and axis, which represent in this image represents anteverted uterus. Long axis of whole uterus is bent forward on long axis of vagina, while anteflexed uterus represent long axis of body of uterus is bent forward on long axis of cervix. This image represents the retroverted uterus, where there is this proportion in the axis between between the cervix and vagina, and retroflexed uterus represent the disruption, the axis between the vagina and cervix. This is anti-flexed uterus, while this retroflexed uterus, and this represent anteverted uterus, while this retroverted uterus. Uterine fallopian tubes lie in the upper free edge of the broad ligament and convey over for the ovaries to the uterus. They open into the uterine cornea. They have four parts. First of them is infundibulum. This is the outer extremity of the tube. It is funnel shaped and it's fimbriated. It extends out beyond the broad ligament through the abdominal ostium and open into the peritoneal cavity. The fimbria spread over the upper surface of the ovary. One of fimbria is longer than the rest. This is called ovarian fimbria, as it is attached to the ovary. Ampulla, which is the common site of ectopic pregnancy. This is wide, dilated, tortuous outer part, which curves over the ovary where fertilization of ovum usually occurs. And there's uterine part close to the cornua. This is the part with the walls of the uterus and open into it. Isthmus, this is a narrow medial part and lead to the ampulla. The ovaries. These are paired oval organs measuring approximately 3 by 2 cm. They lie in the posterior surface of the broad ligament in close contact with the infundibulum of the fallopian tube and attached to its ovarian fimbria. The anterior surface of the ovary is attached to the posterior surface of the broad ligament by a short meso-ovarium that fuses with the surface of the ovary. The lower pole of the ovary is attached to the uterus by the ovarian ligament. A superior lateral extension of the broad ligament and which is being the suspensory ligament run from the upper pole of the ovary to the pelvic side wall. In nulliparous women, it is generally found lateral to the uterus, anterior to the internal iliac vessels and ureters, and inferior to the external iliac vessels. The vagina is an extraperitoneal structure. This muscular canal extends from the uterus to the vestibule, opening between the labia minora behind the urethra and clitoris. It has rectangular shape, being flattened from front to back. The cervix invaginates the upper vagina and divided it into a shallow anterior and deep posterior and lastly lateral fornices. The relation of vagina, we have anterior relation, the bladder and urethra, and posterior relation, pouch of Douglas and ampulla of rectum, perineal body, and anal canal, while lateral relation include ureters, uterine artery, levator, any muscles, and urogenital diaphragm. The blood supply to female reproductive system, we have the blood supply to the vagina and uterus through the internal iliac artery via vaginal and uterine arteries, while the blood supply to the ovary is directly from the aorta via the ovarian artery. Venous drainage, the uterus, uterine tube, and vagina have venous drainage to internal iliac vein, while the ovaries is via the right ovarian vein into the inferior vena cava and left ovarian vein into the left renal vein. Lymphatic drainage include the uterus regarding its fundus body and cervix. The fundus drain into para-aortic nodes, while the body into external iliac nodes and occasionally to inguinal node. Cervix drain to external, internal iliac nodes and sacral node. The ovaries drain to para-aortic nodes, while the vagina, the upper two-thirds, drain into the internal and external iliac nodes, while the lower one-third drain into superficial inguinal nodes. Now we have the congenital Mullerian anomalies. The fused caudal end of the two Mullerian ducts form the uterus, cervix, and upper vagina. The unfused end form the fallopian tubes. The medial septum formed by the medial wall of the Mullerian ducts resorbs, leaving a single cavity. Failure of this process, which means failure of Mullerian duct development and or fusion, leads to spectrum of anomalies often associated with renal anomalies. As we show in this image, these spectrums include either hypoplasia or agenesis of vagina or cervix, fundal tube, or combined of these. Another type, we have unicornuate, which is either communicating with horn or non-communicating, or didelphys, either partial or complete bicornuate uterus, and septate, which is also include complete or partial. هنا نقدر نميز بين الدايدلفيوس والسبتate بالفندس مع اليوترس. إنها ما عندنا didelphys or bicornuate, there is no fundus, while in the septate there is fundus and extend from its septa to the endometrial cavity, while arcuate, which there is indentation from the fundus to the cavity, and also there is drug-related anomalies. That's all regarding the female genital tract cadavers. هسه دكتورة رؤى راح تكمل ويانا على radiological anatomy.
عاشت ايدك دكتورة. إذا تكمل دكتورة رؤى.
أوكي.
السلام عليكم أستاذ.
عليكم السلام.
Now we talk about the radiology of the female pelvis. First modality we have is ultrasound, which is the most common radiological method. MRI, which is the excellent method. CT, hysterosalpingography, and vaginography. Regarding ultrasound, we have either transabdominal ultrasound. The bladder must be filled to provide acoustic window to see the pelvic organ. Here we can see the fundus, endometrium, cervix, and vaginal strip. Also, by transverse scan, we can see both ovaries lying lateral to the uterus. By transvaginal ultrasound, the bladder must be filled. It provides the same zonal anatomy that we can see in transabdominal ultrasound, but with better resolution. Here we have the fundus, endometrium, and cervix. Endometrium will appear different according to the phase that the patient presented with. In early proliferative phase, the endometrium appears thin, linear, and echogenic. In late proliferative phase, it will be thick and trilaminar appearance. In secretory phase, it will be thick, hyperechoic, homogeneous. In this ultrasound view, this is pediatric endometrium. It will be thin, and the uterus, we can see it is small. Postmenopausal endometrium also, it is thin. It must be not more than 4 million, but if the patient is on hormonal replacement therapy, it can reach 10 million. In this picture, this is anteverted uterus, and this is a retroverted uterus, which is of no clinical significance, but it is difficult to be seen in transabdominal ultrasound because the fundus is away from transducer. By ultrasound, we can see the round ligament if there is fluid in the pelvis, and by transvaginal ultrasound, also we can see it by angulating the probe toward the ovary. We can see it attached to the ovary. Sonohysterography involves transvaginal imaging of the uterus and adnexia with saline being introduced into the uterine cavity via a small catheter through the cervix. This distends the cavity and allows evaluation of both endometrial surface and tubal patency. This picture shows endometrial polyp detected by sonohysterography. 3D ultrasound is considered as a problem solving to detect uterine congenital anomaly. Here there is unicornuate uterus, uterine didelphys. This is bicornuate uterus, sepitated uterus, and the most common and which considered is a normal variant, arcuate uterus. The second important modality we have MRI. On T2 weighted image, the endometrium, endocervical, and the vaginal canal, all of high signal intensity, the inner zone of myometrium, and is continuous with the fibrous stroma of the cervix. This is known as junctional zone. It is of low signal intensity, and the outer myometrium will be of intermediate signal intensity. The ovaries is of are hypo-intense on T2 weighted image, and the follicle stand out as a hyper-intense spot in an intensity recognizable pattern. Here there is the uterus, and here there is both ovaries. Dilated gland adjacent to the cervical canal, Nabodian cyst, may be seen as hyper-intense foci. On T1 weighted image, the uterus and ovaries are of homogeneously intermediate signal intensity with poor intrinsic contrast, but the ligamentous structure are very well seen, being of low signal intensity compared to the surrounding fat. In this axial T1 MRI, we can see the round ligaments are crossing the anteriorly from the lateral upper lateral part of the uterus to the inguinal canal, and uterosacral ligament can be seen extended back to the sacrum. Also, we can put gel in the vagina to see the configuration of the vagina on T2 weighted MRI. Here there is anterior fornix, posterior fornix, internal os of the cervix, and external os. Here we can see lateral fornices of the vagina. Dynamic MR imaging. MRI imaging sequence allows study of interaction between pelvic floor musculature and pelvic organ at rest and straining. Measurements are taken from line drawn electronically on the viewing screen. Change in the length and or orientation of these lines during straining allow some objective in assessing abnormal degree of pelvic floor. First line we have is pubococcygeal line drawn between pubic bone and the last joint of the coccyx and define the level of iliococcygeus muscle. H line, the normal is 5 cm, is line drawn between inferior pubic symphysis to the posterior wall of the rectum at the level of the anorectal junction, represent the AP dimension of the levator hiatus. M line, the normal is 2 cm, is line dropped perpendicular from the iliococcygeal line to the posterior aspect of H line. Here we have iliococcygeal line, which is drawn from the symphysis pubis to the last joint of the sacrum. The bladder neck and the vaginal fornices and anorectal junction must be above this line during rest and slightly distended during straining. This is the H line and M line. This MR sagittal MR T2-weighted MRI, we can see uterine prolapse. This is the iliococcygeal line, and there is the uterus prolapse. In CT, on CT, the uterus is seen as round structure of soft tissue density on or behind the bladder. There is the uterus. The ovaries may usually be identified as a small round structure of soft tissue density, occasionally with small cysts. Here we have the bladder, uterus, and both ovaries. The other important modality, hysterosalpingography, is the radiographic procedure to investigate the shape of uterine cavity and the shape and patency of the fallopian tube. By injection of water-soluble contrast media via the cervical canal, this procedure should be performed during proliferative phase of patient menstrual cycle between day 6 and 12. Here there is uterine cavity, both fallopian tube, right and left, and full of dye into peritoneum. Here some anomalies detected by hysterosalpingography: unicornuate uterus, bicornuate uterus. This is septated uterus and arcuate uterus. This is uterine synechia, and this is fibroid. The last modality we have vaginography. This technique outlines the vagina. With contrast, the characteristic rectangular shape of the vagina is demonstrated. Okay.
عاشت يدك دكتورة رؤى باسم. الصور حلوة واضحة، وطبعا حطيت أول. يلا دكتور محمد.
نعم أستاذ.
يلا.
الفندس أوف يوترس.
هو شنو الفحص هذا؟
هو هذا الهيستيروسالبنجوغرافي.
إيه؟
طبعا فلوروسكوبي أوف هيستيروسالبنجوغرافي. فلوروسكوبي.
إيه؟ ليش قلت فلوروسكوب؟
أستاذ لأن يعني السكرين هذا مع الفلوروسكوب، يعني اليوترس
النيجاتيف يطلع بالنيجاتيف. صح.
نيجاتيف.
شكرا. مرتضى بي.
نعم أستاذ. هذا الليفت فالوبيان تيوب اللي اسمه سبارت.
الاسمك بارت مال فالوبيان تيوب. اكسلنت. إيمان حميد.
نعم أستاذ. right corner of the uterus.
corner of the uterus. excellent. نروح على فرح زهير.
نعم أستاذ. دي هو الرايت ساكرو إليك جوينت.
الرايت اس اي جوينت. اكسلنت. وظلت عندنا اخير واحد سؤدة سلمان. اي.
نعم أستاذ. الإي أمبولة أوف ليفت فالوبيان تيوب.
أمبولة اللي الوايدست بارت. اكسلنت. اوكي. استاذ محمد.
عين استاذ العدو وياك. حرف A ياسمين.
نعم أستاذ. The fundus of the uterus.
fundus of the uterus. كل زين. B هدي الكريم.
The junctional zone أمو.
functional zone. C مروان. مروان فائق C.
الاندومتريوم أستاذ.
endometrium. مرتضى D.
نعم أستاذ دي المايومتريوم.
مايومتريوم. فرقان E.
سيرفكس أستاذ.
نعم. cervix.
بداية السيرفكس يعني.
اوكي.
فرقان هذا البوزيشن مال اليوترس شو نقول عليه هذا؟
ريتروفيرتد.
هذا انتيفيرتد وانتي فليكس. انتي فليكس وانتي فيرتد اللي هو هذا النورمال يعني عادة. وشنو الفحص هذا فرقان؟
T2 MRI.
شنو تو MRI؟
T2 MRI.
T2 MRI. excellent. زين. السي السي قاله سي
endometrial line.
هذا الشيء اكثر مما هو الاندوماتريال كافيتي.
نعم أستاذ الكافيتي يعني إذا بيها فلويد معناتها ممكن نشوف.
بالضبط اللي عادة يتجمع بها الفلويد يعني هاي الاشياء انتبهوا عليها. وهذه اكو بعد عندك شيء دكتورة رؤى باسم؟
لا